Hello everyone. Okay, guys, how are you doing all?
Good.
Is my screen visible?
Yes, doctor, it's visible.
Yeah, okay. Okay, should we start? Or how many of you have joined? 24. All right. So we will be doing some pathophysiology and mostly physiology of renal system, okay? So anyone who wants to start?
Okay. Which of the following changes is most likely to be seen in the experimental animals? A group of researchers is studying secondary hypertension in porcine models of renal artery stenosis. During an experiment, a clip is placed that constricts the right renal artery to 30% of its original cross-sectional area. A few days later, hemodynamic and biochemical measurements are recorded and compared to measurements obtained before clip placement. Which of the following changes is most likely to be seen in the experimental animals?
Okay, so what do you think? What are they talking about?
Renal artery stenosis, decreasing
Yeah.
the afferent.
Okay, so for all who do not have understand the stem, so let's go through it. So our researchers are doing some studies, okay, for renal artery stenosis. During a clip is placed where right renal artery. So it is important the right one, okay. So you guys should not be confused in left right. So be careful with reading the stem, okay. Right renal artery. A few days later, hemodynamic and biochemical measurements are recorded and compared to the measurements obtained from the clip placement. Which of the following changes is most likely to be seen in this experimental animal? So let's talk about renal artery stenosis, okay? So yesterday we have talked about GFR and renal plasma flow and filtration fraction, right? We have talked how is GFR increased and decreased, right? So today, one of the concepts from the previous lecture is applicable here. Okay. So what are they doing? They have clipped the renal artery. We can say afferent arterioconstriction, right? What it will do? Decrease GFR and also decrease renal plasma flow. So, if someone do not understand or they were not in the class yesterday, so it's simple concept. We have decreased the flow by constricting the afferent arterioles. Because of that, GFR and plasma flow is decreased. Okay. So, how is RAS activated? RAS system is activated by when it is activated when we have decreased blood pressure, right? And we can say by decreasing osmolarity or decrease in effective circulating volume. This decrease in osmolarity or this decrease in osmolarity or effective circulating volume will be activated by JG cells, right? And it will release renin. Release renin will then activate angiotensin and aldosterone, right? So this is the basics of how is RAS activated, right? So by constricting the afferent arterioles, we have decreased the GFR. By decreasing GFR, RAS is activated, okay? So in the same side, right side of the kidney, the RAS is activated, okay? It will cause increase in blood pressure, okay? It will try to increase effective circulating volume by aldosterone, right? So what what is different over here is the left kidney is normal, right? Are you guys getting my points?
Yes, sir.
Please, can you go over it one more time?
Yeah, so what happening over here is we have constricted the afferent arteriole, right? Which leads to decrease flow through kidney. We call it GFR and plasma flow, right? So when we constrict afferent arteriole, which is occurring in renal artery stenosis, are we have observed in our experiment. So it leads to activation of RAS, right? How is RAS activated? It is activated by JG cells. What are the two factors that is activating the RAS system? Hypoosmolarity, decrease osmolarity, and decrease effective circulating volume. Or we can simply say when blood pressure is decreased, RAS will activate and try to increase blood pressure. Okay. So this is the basic concept. Okay. Got this, doctor?
Yes, sir.
Okay. So over here, the problem is only in right kidney. Okay. So the right kidney will response in response with a RAS activation and will try to increase blood pressure, okay? But left kidney is normal, okay? And what it will do, it will detect this high blood pressure and will try to reduce the RAS effects, okay? So what it will do, now come to the, so this was the basic concept. And what is question saying? What is the which of the following is most likely seen in this animal? Okay. So first one, decrease inferior vena cava aldosterone levels. So aldosterone is high in RAS. Okay. Decrease systemic vascular resistance. So I told you blood pressure is going to increase. Okay. Increase glomerular filtration. So by constricting afferent arterioles, GFR decrease, right? Are you guys getting my points?
Yes.
Yes.
Okay. If I am going fast, tell me, okay? increase renin production in left kidney. So what is the problem over here? The problem is in right kidney. Okay, so it is also incorrect. Okay, so what does the left kidney will do? It will try to minimize the increase in blood pressure because the left kidney is normal, and it will,
Natriuresis.
yeah, so it will
E.
increase
Mm-hmm.
sodium excretion because
Yes, surgeon prescription.
according to the left kidney
Yes.
we have increased blood pressure, right? While
Mm-hmm.
the right kidney thinks that the flow is decreased, GFR is decreased, we have decreased blood pressure. Okay,
Mm-hmm.
so the right kidney GFR is below and it is responding to low blood pressure, while the left kidney,
Mm-hmm.
according to the left kidney, the RAS has increased the blood pressure, right? So it will
Mm-hmm.
respond to increase in blood pressure. Okay, so you guys understand the renal artery stenosis?
Mm-hmm.
Yes, sir.
Mm-hmm. Contralateral. Mm-hmm.
Yeah,
Contralateral. Yeah,
yeah,
contralateral RAS system, how is working. Mm-hmm.
Accordingly,
yeah.
UK.
Mm-hmm.
So I'm gonna talk about two, three important points about the renal artery stenosis. Okay, it is the most common cause of hypertension, secondary hypertension in adults. Okay, this is the high yield point. Got this, everyone?
Yes, sir.
What will be the cause of renal artery stenosis? In normal cases, not like in experiment, we have clipped the right artery, right? But what will be the cause of renal artery stenosis? Plaques, okay? Atherosclerotic plaques, okay? This will be in older people, okay? And what other is, yeah, so it was all about renal artery stenosis. So do you guys got this MCQ, or anyone who does not have understand this?
Yeah, so how do we know it's afferent and not efferent artery? That's been question.
Excuse me, sir. Actually, I couldn't join. So can you give a brief overview of the renal artery stenosis, like a brief, just the main points?
Yeah, so for you, I will I will explain the question that in experiment they have clipped the right artery. Okay, and they are asking about what will be its effect on right kidney and left kidney. So they have clipped the right renal artery. Okay, so by clipping the artery, we have decreased GFR, right? Doctor, the
Yes, sir.
new one.
Yes, sir.
Yeah.
Listen.
So we have decreased GFR and plasma flow, right?
Yes, sir.
And in case of low blood pressure or decreased GFR or decrease effective circulating volume or decrease osmolarity, the Golgi cells
Secrete
will
renin.
activate RAS, okay? And what RAS will do? It will increase the blood pressure. So all this is happening in right kidney, okay? Because they have clipped the one artery on one side, right? While the left artery, sorry, the left kidney is normal, right?
Yes, sir.
So according to the right artery, we have low blood pressure because GFR, blood flowing through, is low, right?
Low. Yes, sir.
So the right kidney tries to increase the blood
Blood.
pressure, while the left kidney thinks that I am receiving normal blood flow, right? So we have we don't have hypotension, right?
Yes.
But when the right kidney increases the blood pressure, the left kidney will try to decrease it, okay?
Yes.
And how the effect will come? If you look into the options, the option E fits perfectly. The left kidney is doing what? Excreting sodium, okay?
Yes.
Got this?
Yes, sir. Thank you so much.
So, okay. So, okay. Yeah, second question, anyone?
An increase in which of the following best explain this patient's current symptoms? A 45-year-old man is evaluated for progressively enlarging neck mass and hoarseness. Physical examination shows an enlarged and non-tender left thyroid lobule. FNAC is positive for papillary thyroid cancer and thyroidectomy is subsequently performed. On the second post-operative day, the patient develops tingling around the mouth and muscle cramps in his lower extremities. Blood pressure is 120/80 and pulse is 82 and respiration is 14. Physical examination shows normal muscle strength and deep tendon reflexing. Light tapping anterior the ear elicits twitching of the lower facial muscles. An increase in which of the following best explain this patient current symptoms?
Yeah,
That
so
Chopstick sign explained, right?
yeah, so what is happening over here that we have a person 45 years old with a neck mass. So they have given the diagnosis papillary thyroid carcinoma, and they have operated by doing the thyroidectomy, right? So what happens after the thyroidectomy? The patients develop tingling, okay, muscle cramps, okay, and physical examination shows normal muscle strength and reflexes. Light tapping the interior of ear elicit twitching of the facial muscles. An increase in which of the following best explain this patient's current symptoms? So what is happening over here that we have removed the thyroid, right? Thyroid is removed. What are the signs? Tingling, muscle cramps, and I'm
Yeah,
gonna explain this, okay? Don't worry. So we have decreased calcium.
yeah,
What is
hypocalcemia.
this? Tapping on the
Yes.
ear, tapping on the interior of the ear, or we can say tapping on the facial muscles. The facial muscles twitches. We call
Yeah.
this chopstick,
Just the trousers. Yeah.
chopstick sign, right?
Mhm.
And what is
Yes.
Trosov?
And trousers.
What is Trosov sign? When we,
When we get in blood
Put
pressure.
the
Yeah.
yeah,
And blood pressure cuff.
when we
Mm-hmm.
inflate the cuff, blood pressure cuff, we see the muscle cramps. Okay, got
Yes.
this. So when we increase the pressure in blood pressure cuff, the same hand muscles will muscle cramps, we can say simply, okay. So we have decreased calcium, okay. So what do you think could be the possible cause of decreased calcium? What do you
Actually,
think, guys?
It's the injury to the parathyroid.
Yeah. So what is happening over here is they have removed the parathyroid gland.
Yeah,
Okay.
parathyroid gland. Yeah,
Yes,
yeah,
yes.
And
parathyroid
parathyroid gland do what?
is maintaining the
Increase the absorption
Increasing
of calcium.
calcium in the
calcium
blood.
in
Yeah.
serum. Okay. How
Mhm.
is it doing? From bones, okay,
Mhm. Mhm.
kidney, and GI, we can say intestines. Okay. How it is doing? I am explaining the bones, kidneys because some MCQs will come on these concepts. Okay.
Mhm.
It increases bone resorption. Okay.
Mhm.
How is it doing in kidneys?
It depends on the kidney alpha hydroxylase. But unfortunately, alpha hydroxylase stimulating by parathyroid hormone.
Yeah.
Alpha hydroxylase is the metabolism of the active vitamin D, which is how can I say, stimulating the reabsorption of the calcium,
Okay.
vitamin D in the GIT, but the 1 point no 25 it's not active vitamin D in the kidney by alpha hydroxylase. They
Yeah.
convert
Okay.
into 1.25 cholecalciferol, active vitamin D, which
Yeah.
is yes, with the in GIT by epithelial cells is increasing reabsorption calcium, which are getting alimentary.
Okay.
That's it.
So I'm
That's it. Uh-huh.
I'm gonna make
Yes,
it
yes. So sorry.
simple
Yeah.
for you. Okay.
Okay. Mm-hmm.
Okay.
Yeah.
Thanks for assistance.
Mm-hmm.
Okay. And what does it do in kidneys? In distal convoluted tubule, it will increase
Mm-hmm.
reabsorption. Okay. What you are talking about in is GI. Kidney produces kidney produces active vitamin D.
D. Mm-hmm.
125 cholecalciferol or we can say 125 dihydroxy vitamin D. Okay. So it is activating vitamin D, which is responsible for increased GI, calcium, and phosphorus reabsorption. Okay, or we can say phosphorus absorption. Okay, so this is the basic mechanism of parathyroid gland. Okay, so one function of the parathyroid gland is it is by activated by decreased calcium, right? So
Yeah.
it will increase calcium in serum. The second function is we call it phosphorus trashing hormone. Okay,
Yes.
so it will
In
decrease
Yeah, I
phosphorus
know.
phosphorus. How it will do it? It will remove it from
serum.
proximal convoluted tubule.
Convoluted. Yeah.
Normally it is reabsorbed, so it will decrease the reabsorption of the phosphate. Okay, so we we have said that vitamin D is absorbing calcium and potassium, right, from gut. So some of the students confused in this point that potassium is increasing vitamin D, which is increasing potassium, right? But we say that parathyroid is responsible for decreasing potassium, right? And are you guys getting my point?
Potassium.
What happening over here is,
Phosphates or
Phosphorus.
potassium?
yeah, anyone? Yeah, so what is happening over here is parathyroid is acting on the kidney, right? And while kidney is increasing calcium reabsorption and phosphate, but the effect of parathyroid on phosphorus is very significant in proximal convoluted tubule reabsorption. Okay, the other effects are not that much significant, so don't confuse the parathyroid action uh, doing something with phosphorus in bones and intestine. The main effect that is causing the decrease in phosphorus is in proximal tubules. Okay, so you got the parathyroid functions. We discussed the parathyroid. Okay, so it will help in our questions. Okay, so what do you think now? Why is calcium decreased? We don't have parathyroid. Okay, we don't have parathyroid because of surgery. Okay, so what will happen?
Calcium will be decreased.
Yeah, so calcium is decreasing, but how? According to the options, we are going to explain the options.
Urinary excretion.
So, started from the first one, option A. So, calcium binding to albumin, I think we have discussed this in Palmo. How is it affecting?
There will be less free calcium in the blood.
No, I am asking about albumin binding to. It will be happening in when pH is increased. In case of alkalosis, this mechanism is functioning okay. In case of increased pH, the calcium will bind to albumin. Okay. Normally the calcium is bound to normally the calcium is bound to hydrogen, right? But in case of alkalosis, the calcium have open site for attaching in ion because we don't have the or we have decreased hydrogen, okay, in alkalosis. So while normally it binds to hydrogen, okay, but in case of alkalosis it will bind to albumin. Okay, got this?
Yes.
Yes, sir.
Okay, what about option B? Calcium release from bone, it is the function of parathyroid hormone. We don't have parathyroid. Okay, hydroxylation of vitamin D with the help of parathyroid hormone, kidney does it, right? And we don't have this. Okay, intestinal phosphate reabsorption, same with the help of activated vitamin D. So urinary calcium excretion, because PTH is not present to PTH is not present to do what? To reabsorb calcium, right?
Reabsorb
So
calcium
no
in
reabsorption.
pieces. Mm-hmm.
So
Excretion.
excretion is increased. Okay.
Mm-hmm.
Yeah. So let's jump to another MCQ. Anyone, please?
Okay, here we have which of the following most closely resembles the metabolic effect of substance X? We have two boxes here, substance X, which has serum calcium and urine phosphate. A group of researchers is developing new drugs for osteoporosis. They are testing a new drug, and one of them is substance X that exhibits the following metabolic effects when given via an infusion in varying doses, as shown in the graphs below. So, which of the following most closely resembles the metabolic effects of substance X?
So it's an easy MCQ. If you look into the graph, you will see that we have serum calcium over here. And what is the drug X doing? Increasing the serum calcium, okay? Okay,
Yes, sir. And
so the drug X is
Yes, sir.
increasing calcium, okay? And we have urine phosphate over here, and it is also increasing. So what is the drug X doing? Decreasing phosphate, right?
parathyroid effects.
Yes, sir.
So it is
PTO.
similar to PTH.
Yeah, it's the like previous question is about parathyroid. Yeah.
Yeah.
Mm-hmm.
So if we got some time, I will explain the other options. Okay. Don't worry
Mm-hmm.
at the end. And if not, so the question is easy. Okay.
Mhm.
Mm-hmm.
Yes.
No, this is it is not easy. Parathyroid
Excuse
hormone.
me. Yeah.
No,
Sorry.
I mean no parathyroid hormone and kidney is not easy. You know the one of the
But
endocrine and
yeah, yeah, yeah. But we will don't worry,
yes,
we will
yes.
discuss it
Mm-hmm.
again in endocrine module. I
Yeah.
will be doing
Mm-hmm.
endocrine with you guys. Okay.
Mm-hmm.
After this system, Dr. I
Mm-hmm.
think Dr. Imran will be doing gastro, and after that
Mm.
we will be doing endo. So don't worry about the
Uh-huh.
endocrinology. Okay. So it
Okay.
is some type of endocrine in
Mm-hmm.
renal system. Okay.
Yes.
So don't worry.
Mm-hmm.
Yeah. Anyone, please.
Which of the following changes most likely contributed to acute deterioration in this patient's condition? A 43-year-old man comes to the office due to swelling of the legs and abdomen. The patient has a history of alcohol-induced cirrhosis and his ascites had been well controlled with furosemide. Over the past week, he had increasing bilateral lower extremity and abdominal swelling despite taking a diuretic as prescribed. The patient reported no changes in dietary sodium or water intake but states that he had been taking over the counter ibuprofen after injuring his back recently. He stopped drinking alcohol 2 years ago and does not use tobacco or illicit drugs. Physical examination showed 3 plus bilateral lower extremity edema and moderate ascites, which of the following changes most likely contributed to acute deterioration in this patient.
So what do we have? We
So
have
ascites like liver cirrhosis. He was taking furosemide, but currently he's started on an NSAID. So we
yeah,
actually study the effect on NSAID on the arterioles. So NSAIDs
yeah,
include
great. Yeah,
prostaglandin.
yeah.
So we
So let me make it easy for the others. Okay, you got this. Great. So we have a patient of cirrhosis. Okay, having ascites using diuretic. Okay, increasing bilateral edema, swelling. Okay, the patient reports no changes in dietary sodium, water intake, but states that he has been taking over the counter ibuprofen, right? So he stopped drinking alcohol, does not use tobacco. He has uh, edema, bilateral edema. So I have told you in some of the questions they have made the stem very long just to confuse you. But overall, we have a use of diuretic, a loop diuretic. He is using diuretic, okay. And why is he using this? Because he have cirrhosis, and cirrhosis is causing SIT. So some doctor have given him do diuretic to reduce the fluid. Okay. So Now he has been using ibuprofen in NSAID, okay? Got this MCQ.
Yes, sir.
So, which of the following changes is most likely to contribute acute deterioration in this patient condition? So, they are asking about the effect of NSAIDs in patients like liver cirrhosis, or we can say decrease effective circulating volume, because normally when we take NSAIDs, the effect is not that much, okay? But in conditions like cirrhosis or sepsis or other conditions where the effective circulating volume is low, the kidney is not receiving enough blood. So the effect of NSAID is very prominent in such cases. Okay. So what would be the effect? So tell me what NSAIDs do to prostaglandins.
A gonna be because here ibuprofen patient taking renal
Yeah.
prostaglandin level
So what
going
will happen
down.
to
Yeah,
yeah? So what will happen to prostaglandins?
Prostaglandin will be decreased.
yeah,
Yeah.
the
Decrease.
blocking. Yeah,
Yeah.
PGF1, PGF2. Mm-hmm.
Yeah. So
Mm-hmm.
the prostaglandin is decreasing, and we have discussed this, or we know this, that the prostaglandins are, when prostaglandins are
Decrease.
decreased, what will happen?
Va-
Normal,
um,
it is,
Afferent arterial vasoconstriction and
yeah,
GFR gonna be go down.
it will be causing
Mm-hmm.
constriction, right?
Yes.
So now you can tell me easily what will happen. We have decreased
Mm-hmm.
prostaglandin, right? So
Mm-hmm.
these three are excluded.
Mm-hmm.
What is happening to GFR? Because of constriction,
Decrease.
Decrease
decreased.
too.
Mm-hmm.
Okay. And urinary sodium excretion, it
Mm-hmm.
is
Decrease.
Decrease
A
also
too.
decreased.
decrease.
But let me explain why the urinary sodium is decreased. So, what happening here is, what does the furosemide do? So, it is blocking sodium chloride
Potassium
channels, okay?
retinol.
And what is the other function? It is increasing prostaglandins, right? These two are the important functions of furosemide. But due to inserts, this effect is decreased. So the overall effect of furosemide is decreased. Okay, got this?
Yes, doctor.
Yes, yes,
So
yes.
if we have
Yes, sir.
nor if we are
Yes.
have okay, sure. So I should go on, right?
Please, can you go over it again?
Sorry,
Can you go over it again?
the whole question or the last part?
The whole question one more time.
Okay, so we have a patient having cirrhosis. Okay, having cirrhosis. Okay, and he has ascites. For ascites, he is using furosemide, okay? But he is taking over the counter drug, which is ibuprofen instead, okay? And the question is asking, what is the effect of ibuprofen on his kidneys, okay?
Mm-hmm.
So I have told you that normal patients, sorry, in a normal people, the effect of NSAIDs is not that much, okay? It is causing all these effects, but in case of cirrhosis, the effect of NSAIDs is very increased, okay? Because we have low circulating volume, okay? We already have decreased volume flowing through kidneys, and we are more decreasing flow or GFR by NSAIDs. How? Because prostaglandin is blocked by NSAIDs. So we have decreased GFR. Got this?
Yes.
We have decreased prostaglandins, We have decreased GFR and decreased sodium excretion. Okay.
Mhm.
So you were telling something about you need sodium excretion.
Yeah.
So what was that point?
So let me explain. What is normally furosemide do? Furosemide blocks sodium potassium to chloride symporter. Okay. You can
Okay.
simply remember that furosemide is blocking the reabsorption of sodium and chloride. Okay. So it
Okay.
will go out, or we can say excreted. Okay. Got this?
Okay. Yes, sir.
And the second function is it is stimulating prostaglandins. Okay. These
Okay.
prostaglandins increases renal plasma flow, right?
Yes.
So
Right.
what does NSAIDs do? You have to be very attentive in this point, okay? What does NSAIDs do? NSAIDs decreases the plasma flow, right?
Yes.
So we have decreased plasma going through these channels,
Okay.
right?
Yes, sir.
So the overall effect on these channels is being decreased, okay?
Yes, sir.
Got this?
Yes, sir. Thank you so much. Thank you. Appreciate it. Thank you.
طب استفاد مني سوايا من سما وشوف
Yeah, anyone please? Anyone?
Which of the following is most likely primary acid-base disorder in this patient? A 36-year-old man is brought to the emergency department due to confusion, nausea, and decreased arousal. He is unable to answer question and no other history is available. Temperature 36.7 Celsius, pulse is 86 and respiration are 22. Arterial blood gas and serum chemistry results are shown as below. pH is
Yeah,
7.25
so
per.
it's okay, it's okay. Don't need to go through all this. Okay.
Okay.
So what is this question asking us? What do we have? We have pH of 7.25, right? Sorry, a 36-year-old with confusion, nausea, decreased arousal. He is unable to answer question and no history is available. Okay. Temperature is normal, pulse is normal, respiration is slightly increased. Arterial blood gas has given the values. Which of the following is most likely? So in STEM, we don't have that much information. All the information present is in the table. Okay. So normal pH is 7.35.
35 to 7.45.
35 to
Or five.
7:45.
Yeah, so this is very important. Some of the students just say 7.3 and 7.4, so it is wrong, okay? Because a slight difference like 7.46 is causing an effect, okay? So we have, what do we have? The pH is decreased,
Low.
okay?
Mm.
Low.
What is sodium levels? Normal,
Normal.
Sodium is
almost
normal.
normal,
Mm.
right?
Yeah.
Normal.
What about potassium?
Normal.
Potassium is normal.
Potassium is normal but in the low limit.
Chlorine is normal is 100,
Chlorine is
okay?
normal. 70 to 100.
Yeah.
105.
Okay, so what is the bicarbonate? It is
Decreased.
Low.
increased,
Decrease.
right?
Decrease.
Normal is 24.
24 to
And
28.
what about carbon dioxide? It is Decreased. Okay. So
Very good.
Decreased.
we have decreased pH, decreased carbon dioxide, and decreased bicarb. So if you look into the options, they are asking about what type of problem it is, metabolic acidosis, alkalosis. So I think that most of the students face difficulty in understanding concepts of concepts of acid base, right? So I want to go very quickly through acid base concepts. Should we do it?
Yes, sir.
Okay.
Yeah, yes, sir, please.
So pH
Yes.
7.35 to 7.45. Okay.
Mhm.
If pH is below 7.35 and if above 7.45. Okay. What do
Mhm.
we call this?
Acidosis,
Yeah, and what is this?
alkalosis.
Alkalosis.
So we have this much of pH, right? So what is causing the acidosis? What is the cause of acidosis? So we have two, right? Either respiratory or metabolic, right?
Metabolic. Yeah.
So
Mhm.
how do we know what is the cause and what is the compensation? Okay.
Mhm.
So the easiest way to understand this is it's very simple. You don't need to complicate it for yourself. Okay. By this simple, easy concept, you will get all the questions. Okay.
Okay, sir.
Okay.
So you will look into the bicarbs, bicarbonate, and carbon dioxide.
Mhm.
Inside note, what do you think? Carbon dioxide is acidic, right?
Yeah.
Yes.
And bicarbonate is
Basic.
basic.
But
Okay.
Hmm.
So yeah. So what are we saying? Acidosis, right?
Yeah.
So if acidosis, carbon dioxide is acid, it will be
Increase.
increased. Okay. And if this is
Hmm.
increased, what will happen? What we called it? Respiratory, right?
Yeah.
Respiratory acidosis. So whenever you look into into the questions, from looking into carbon dioxide, you will say it is respiratory, okay?
Okay.
mhm.
And from bicarbonate, it is basic, right? Bicarbonate is basic, right? So
Yes.
what will happen to the bicarbonate in acidosis? It will decrease, right?
Decrease.
So
Mhm.
what will be the what will we call it? Metabolic
Yes, sir.
acidosis.
Alkalo.
No, acidosis.
So don't confuse whenever you look into the pH, first decide from pH. Okay. What is it?
Yeah.
Okay. So the
Okay.
first step is looking into pH. The second step is look to carbon dioxide for respiratory. Okay.
Okay.
And look to the
Mhm.
bicarb for metabolic. Okay.
Mhm.
And
Okay.
same is occurring over here. Okay. Just do it
Mhm.
yourself. For alkalosis, it's the same concept, okay? You will understand,
Mhm.
okay?
Okay.
Mhm.
So after this, we can discuss the, let's take this one, this example, okay? What do we have? We have decreased pH, and I am repeating it again and again so that you guys understand this, okay? It is very important, okay?
Okay,
What
sir.
is
Thank you so
happening?
much.
pH is decreased, so we have acidosis, okay? What is the
Okay.
cause
Mhm.
of acidosis?
Could
Carbon
be the
dioxide is
increased carbon
increased. So
dioxide.
we call it respiratory acidosis, okay?
Acidosis. Okay.
Mhm.
Now tell me what will be the compensations? Compensation if the problem is
Metabolic
by,
acidosis.
That will
yeah,
be
Renal. Renal.
Yeah, so
Compensation.
if, yeah, so the compensation will be renal, okay?
Mm-hmm.
And how will the kidneys
Reabsorb,
compensate? We
reabsorbed
have,
bicarbonate.
yeah, so the concept over here is very simple. We have acidosis going on, right? We want
Yeah.
to neutralize it. And
Mm.
bicarb is, I have told you bicarb is basic, okay? So it
Yeah.
will
Mhm.
increase bicarbonate, okay?
Okay.
Got this? So it is
Yes.
very easy. Don't confuse it. First thing you need to do is, the first thing you need to do is to look into pH, okay?
Yes.
And if you want to know, is it respiratory or metabolic? For respiratory, you will look into the carbon dioxide. And for metabolic, you will be looking into bicarbonate, okay? And what are the normal values? 40 for carbon dioxide and 24 for bicarbonate, okay?
Bicarbonate. Okay.
We will discuss the compensation in great details. Don't worry. Okay, so you will get the mix type of acidosis, alkalosis from the compensations discussion. Okay,
Mhm.
so what is A9 gap?
Unmeasured atoms.
So we calculate is, it is sodium minus chloride plus bicarb,
Bicarb.
or we can say sodium minus chloride minus bicarb. Okay, normal is,
10 to 12 or 14.
yeah, so some books are saying 10 to 12 or 14. Okay,
Mhm.
so in question, we will discuss it more. Okay, don't worry. In question, what do we have? So first thing you need to look into pH. We have acidosis, right?
Yes.
So if carbon is low or bicarb is,
No.
tell me.
Low.
CO2
Sorry. If
increased.
carbonate,
Is
carbon dioxide
increased.
is high
i-
or
Mm. Is
bicarbonate is
acidosis.
Low.
Mm.
low, bicarb.
Mm.
If you are confused, just look into this concept. Carbon dioxide is acid and bicarb is base. Okay.
Basic. Mm.
So
Mm.
now look into the question. What do we have? Carbon dioxide is
Decreased.
Low.
Yeah.
okay. So it
Mm-hmm.
is not the cause of
Respiratory acidosis.
acidosis. So we don't have respiratory acidosis. Okay.
Okay.
Mm-hmm.
So carbon dioxide is not the cause. Now look into the
Mm.
bicarbonate.
Yeah, metabolic acidosis.
So we have metabolic acidosis. So you guys now can
Bicarbonate
uh,
is low.
now you can
So it's
tell
metabolic
from the
acid.
ABGs that what is the condition, right?
Mm-hmm.
Yes.
Okay.
Yeah.
Now we have to look into the
A9 gap,
anion gap. Okay. Tell me how much is sodium?
36,
136.
Okay, 136,
102,
102.
so
Mm-hmm. And
30,
then
No,
30.
not
12.
not 102. It's 90, right?
So we want
90.
90.
Okay. You are right. Okay, you
What
are right.
is
I'm sorry.
mm,
Mm.
So
Mm.
136
102.
minus 102 is 24.
102.
So
Mm.
what is this?
90,
Anion gap.
90
Anion gap.
minus
metabolic acidosis.
Got this?
Yeah.
Yeah, anyone.
Which of the following changes in the patient's acid
Excuse me,
base?
can you please show the previous option? It was so quick, I couldn't see
yes,
that.
yeah, we can see the last bit. Anion gap, you said sodium minus chloride minus, what was the other one?
Yeah. Let me do it again. Sodium minus chloride If you are taking it into bracket, don't confuse it. You will
Okay.
add bicarbonate, okay?
Ah, okay.
Mhm.
And if you are not taking it in brackets, then
Okay.
first subtract this and then subtract this. Or first
Mhm.
add both of these and then subtract it from sodium, okay? Normal is 10 to 14, okay?
Mhm.
Okay.
You are looking into the options, so other options are already explained, like why not respiratory, why not 99 gap, okay? Right?
So if it's between the normal value of anion gap, then we say it's anion gap metabolic acidosis.
No. So
Or
if it is more than 14, it will be anion gap metabolic acidosis, okay?
more than, yeah.
And
Okay.
if it is in normal range, so it don't have any anion gap. So
Oh.
non-anion gap, okay?
Oh, okay. So, okay. Thank you.
If we have gap, the gap will be more than 14, okay?
Oh,
Okay, thank you.
thank you,
Okay,
sir.
no problem. So anyone, please? Yeah.
Okay, we know
Okay,
it.
sorry. Yeah.
In the patient's acid-base physiology is most likely to be seen. A 24-year-old man who lives in the elevation near sea level goes on a multi-day hiking trip in the Colorado mountains that ascends to an altitude of 4,000 over. The next 3 days, the patient developed diffuse headaches, nausea, and difficulty sleeping. The patient also notes a mild fatigue and slightly dizziness changes in position. He has no medical conditions and take no medications. He does not use alcohol, tobacco, or illicit drugs. The following changes. So it's actually increased altitude physiology will be happening.
Yeah, and we
Hyperventilation,
have discussed this, right?
that's
You
right.
know,
Yeah.
you know this, right? Increase carbon dioxide removal, right?
Yeah, hyperventilation and
So
respiration.
we will have decrease carbon dioxide. We have removed it, right?
Yes, sir. Continue.
Yeah. So we will have respiratory
Alkalosis.
alkalosis. All of you are getting this, right?
No.
Okay. Don't worry. What happens in we have discussed this in great detail in Palmo section. In on altitude, the oxygen level is low. Okay.
Mhm.
So we have hypoxia, which leads to hyperventilation, right?
Mhm.
And it is hyperventilation is removing CO2 from body, okay?
Mhm.
So when we have decreased CO2, what it will be? Respiratory alkalosis, okay? Why not
Mhm.
acidosis? Because we have decreasing carbon dioxide.
Carbon
And
dioxide
why respiratory? Because of hyperventilation. Easy,
ventilation.
right?
Yes.
Got this?
Yes, sir.
Yes, sir.
So
Thank you.
what are the options? It is easy now.
Alpha will be the option A. We will,
No, so don't look into the mark. Okay, it is not correct. Okay,
sorry, sorry.
sometime it comes by itself. Okay,
Yeah. We will actually having increased pH because of the alkalosis.
yeah. So we have
Increased
respiratory alkalosis. Okay,
Yeah, respiratory alkalosis.
so we have three options with increase
pH.
pH. Okay, so if we have increased pH, what will happen to the the secretion of
We will have
hydrogen?
increased secretion.
Decrease.
We
Decrease.
do not want to remove. We It is simple. Just think about it. We do not want to remove
Hydrogen, yeah.
acids or hydrogen further because we already have increased pH, right? Got this?
Yes, sir.
So
Yes.
we will have decrease excretion. No changes, not correct. Increases, not correct. Okay. So we almost got our answer right. But what about this? Why bicarbonate is decreasing? Simple.
Already answered.
Bicarbonate is basic
Compensation.
and we will decrease it for compensation. Okay. Got this or not?
Got it.
It is
Yes,
basic, so we are decreasing it. Okay. Kidney is decreasing it. Okay. So option B. So we will come back to this question of potassium excretion because it needs some explanation. So let's come to question number 8. Yeah, anyone please?
A 43-year-old woman with a borderline personality disorder is brought to the emergency department after taking an undetermined number of pills. She is lethargic but irascible. She refuses to answer questions. Blood pressure is 110/60, heart rate is 120, and regular. Laboratory results are as follows.
What are they
So,
asking?
okay,
Which of
so
the
which of the
following?
following best describe this patient as his acid-base
Yeah,
disturbances?
so we have again the same question. What is the condition? Okay. So look into the ABGs. We have sodium this much, chloride, bicarb, pH. Okay, we have marquee important findings. Okay. So the pH is 7.46. Increased, right?
Yes.
So what I have told you that you should be very specific about 7.45 and 7.46. Okay.
Okay.
Now look into the carbon dioxide.
East.
Carbon dioxide is
Decrease.
decreased.
Low.
So what is the condition?
Alkalosis.
Alkalosis.
We have
respiratory.
Alkalosis.
respiratory alkalosis. So from pH, we have decided that it is alkalosis. Okay.
Okay.
Mm-hmm.
From carbon dioxide, we have decided it is respiratory. Okay.
Respiratory. Mm-hmm.
But the problem, the problem over here is how much is bicarbonate. So bicarbonate is also decreased.
Yeah.
So it is also,
Metabolic compensation.
Compensation. Yeah.
yeah, but it is not the compensation. Think about it.
It's actually mixed by like respiratory and metabolic both, right?
Yeah, but how would you know that it is mixed? It is very, very important concept. Okay. So we have,
Timing, maybe, because it takes time for the metabolic
yeah,
to
but how would you know from the
So
stem?
we
Like,
use the formula to calculate the compensation, right?
yeah, we have the
Quintal
formulas. So from the bicarb, what is it? Metabolic.
13.
What is it? Metabolic
alkalosis.
Mm-hmm.
acidosis.
Acidosis. It's always acidosis. The
Okay,
best.
so the pH is 7.446, but we say it's acidosis. Why? Because it is not the compensation, and we will discuss why it's not the compensation. Okay, you will understand this in a while. Okay, anyone have any question? So what we so doctor, please turn off your mic. Yeah, any question, please? So we were
Can
discussing
you
why,
explain?
yeah, why it's not compensation. It is not a compensation. Why? So we have formulas for if we have metabolic acidosis. This one is difficult, the rest are easy, okay? For metabolic acidosis, what will be the compensation? You guys have to tell me, okay?
Respiratory alkalosis.
Respiratory.
Respiratory.
Respiratory alkalosis.
Yeah, so how will it be happening? Increase in
Hyperventilation.
Hyperventilation.
increase in carbon
Respiratory.
dioxide, right? But the formula is 1.5 into bicarbonate plus 8. Okay, if we have metabolic acidosis and we want to know is the compensation is correct or not, right? So we will look into the value of carbon dioxide and check it with formula, okay? So if the bicarbonate have a specific value, okay, so we will multiply this, like if for example if it's 20 and plus 8, so it becomes 30, and plus 8 it becomes 38, right? So if the carbon dioxide is 38, then it is compensation, okay? But if the value is more than 38, in such case it will be mixed type of
Mix.
acidosis and alkalosis, okay? You got this? The formula for metabolic acidosis compensation is difficult. You have to memorize it. The rest are easy, okay? We are going to discuss with our own stem so you will understand it better, okay? What do we have over here? What was our problem in our question?
Respiratory. We have
Respiratory?
respiratory,
Respiratory
yeah,
alkalosis,
alkalosis.
right? Respiratory. Now you will understand it easily, okay? Respiratory alkalosis, okay? So we want to know is the compensation is correct or not, okay? So respiratory alkalosis will be compensated by what? Increase in,
Bicarb.
Bicarbonate by kidney.
Bicarbonate reabsorption.
yeah. So we will have decreased bicarbonate, right?
Yes.
So
Decreased
if
bicarbonate reaction.
now all the I have told you the metabolic acidosis formula you have to remember, right? But the rest three are easy because the compensation will be for increase of 4 in or decrease of 4 in bicarbonate level per increase of 10 carbon dioxide, okay? You got this? If we have, like in our example, what is our value? We have 19, right? We have carbon dioxide 19, okay? Normal is 40. So the difference is 20, right? Almost 20, 21, okay?
Yeah, totally. Yeah.
Getting this? So the compensation for this will be 8, okay? 4 for 10. So for 20, it will be 8, okay? So the bicarbonate will decrease only 8, okay? Normal is 24. It will be how much?
16.
Yeah. So if in our case, if the bicarbonate is 16, okay, it will be normal compensatory mechanism. Okay, you are getting this or not?
No, no, no.
No, I'm
Yeah,
not getting it.
sorry.
I didn't get the eight. How you get that eight
Yes.
thing?
Yeah, yeah.
Is
I'm
it
sorry.
constant?
I have made this difficult for you. I'm sorry. Yeah. Okay. So for respiratory alkalosis, what will happen? We will decrease bicarbonate. Okay.
Mhm.
How much decrease is normal? How much decrease is normal? Or we can say how much decrease is considered normal for compensatory mechanisms. Okay.
Mhm.
Okay.
Okay. So
Yes.
Mhm.
we will know this from our formula, which is saying us, note this point, okay, that for a difference of 10 carbon dioxide, okay, the normal difference in bicarb will be 4. It is simple, okay,
Okay.
like how? So I will explain in simple terms. We have how much bicarb? How much bicarb we have?
13.
13.
13.
And how much carbon dioxide we have?
Uh,
19.
19. So we have
19.
19, we have 19 carbon dioxide. Doctor, please turn off your mic. So we have 19 carbon dioxide, right?
Yes,
Mhm.
sir.
So how much is it decreased? From 40 to 19, right? We have a
Mhm.
difference of 21,
21.
right? So the
Yeah.
Mhm.
body will compensate this 21 by bicarbonate, right?
Bicarbonate.
So who is talking? Please turn off your mic. The concept is difficult. Students are disturbing. Got this or not? We have the difference of 21, okay?
Yeah.
Yes.
Sir,
So that would
completely
mean 8
what is normal?
Let,
bicarbonates, right?
let me complete, you will understand, okay? So the difference is 21, okay?
Mhm.
And for each 10 difference, we will have normal for difference in
Bicarb.
bicarb, okay?
Mhm.
So if the bicarbonate difference is 8, we will say it is normal compensation. Got this or not?
Yes.
Yeah.
Why
Because
8?
for 10,
Is this 8 a
we have
constant?
4. This 4 is
Well,
constant, okay? This
Okay.
4 is constant. If the difference
Mhm.
is 30, so 12 will be normal.
Okay.
If the difference is 10, 4
I guess,
is
doctor, we
normal.
need to multiply by 2 and divide to 5 so we can get this. So because in 10 it's 4. So if you multiply 10 by 2 divided by 10 over 4,
Yeah,
it
so
will be like 5 over
don't
2.
make it difficult for
I make
yourself,
it like
okay?
that.
Yeah, you have
I felt
understand
easier.
it. Yeah, you have understand it from that formula. It is okay, okay? That is also working over here. But simple is for each 10 difference in carbon
For
dioxide,
bicarb. Mm.
we will have a difference of 4 in bicarbonate and it is normal, okay?
Mhm.
If the difference is more than this, it will be
Mhm.
abnormal, okay?
Mhm.
You got this concept or not?
So in other words,
Yes.
we can
Yeah.
divide the bicarbonate value
Yes.
by 10 and multiply by 4.
Yeah, if you are easy with that
If you so
formula, it
wish.
works the same,
Mm.
okay? It works the
Okay.
same way, okay?
Okay.
Okay. So now come to the question, how much is, now tell me the values, okay?
Mm.
We have, we have what? Respiratory alkalosis, right?
Mhm.
And how much is the, sorry, 19 is carbon dioxide is 19
Mhm.
and
Mhm.
bicarb is what?
13.
13. So for this, the bicarb normal would be 24 minus 8, 16, and it is 13. Normal would be 16, and it is 13. It is below normal, okay? And it is below
Oh my
normal,
God.
okay? So that's why we are saying it is metabolic acidosis and respiratory alkalosis both. Okay?
Okay. Where did you get the 8 from? 24 minus 8.
Yeah. Let me explain it again.
Sir, from where
Normal.
is this 24 coming?
24 is the normal
24,
bypass.
Yeah, okay.
24 is normal bicarb, I
Normal
believe.
bicarb is 24, okay?
Okay.
The difference of carbon dioxide we have normal is 40, our value is 19. We have
20
this,
less.
right? 21. So I have taken it is 20 for simplicity, okay?
Mm-hmm.
And we know for 10 we have 4 normal. So for 20 we have 8 normal. That's why I am subtracting 24 minus 8. Got this?
Yes.
Mm-hmm.
Let me do it once again. You're not bored, right?
Mm-hmm.
No, sir. No, not at all.
No, we are
Sorry,
not.
why is my pen not working?
Mark
Wait,
and walk.
Yep.
sorry.
Tired explaining the same concept actually.
Maybe. I don't know what is wrong. Okay, now. Yeah. So for compensation, now I am making it simple, you will understand, okay? For compensation, if we have a difference of 10 in carbon dioxide, so the difference of 4 will be accepted for bicarb, okay?
Mm-hmm.
If it is more than 4 or less than 4, it will be abnormal, okay?
Mm-hmm.
Yeah. Now we have carbon dioxide of 19, okay?
Mm-hmm.
The difference between normal carbon dioxide and 19 is 21.
Mm-hmm.
We take it simply 20 for easier math.
Mm-hmm.
So the carbon dioxide is decreased from 40 to 20, okay?
20. Mm-hmm.
We have the difference of 20.
Mm-hmm.
You got this 20 difference?
Yeah.
Yes. Mm.
So how much change in bicarbonate will we accept? 8, because for
8,
10 it is 4.
4.
For 20 it is 8. For 30 it will be 12. For 40 it will be 16. Okay? Getting it or not?
So,
Yes, we're getting it. It's like 4
yes, sir.
times 2 is
Yeah,
8.
so it is
Then
increasing
4
by
times 3 is
4,
12.
4 folds.
By
Okay,
4.
4, 4,
Yeah.
4, 4. Okay?
Mm.
Yeah.
Mm.
Now compared, now let's check this. Is it the difference is actually 8 or not in bicarb? Okay? So
Mm-hmm.
we have bicarbonate 13. We have
13.
13. Normal is 24. So
Yes.
we are getting how much? 11. So it
Mm-hmm.
is abnormal, right?
Yes. This is
So
It
it,
more
is
than
below
8.
normal.
it is more than 8.
More than 8. Mm.
Yeah. And bicarbonate is decreased. So we are saying it is acidosis. Which type of acidosis? Metabolic. Okay. You know
Mm.
these concepts, okay? I
Mm.
think you guys have mastered it, right? Or not?
Yes,
Inshallah.
I
Maybe
think we just got it. We
subsequently,
just got it.
subsequently we'll get it.
Yeah.
Subsequently we'll get it. Mm.
So in first place, what do we have? We have respiratory
Metabolic acidosis.
alkalosis
Alkalosis.
We have at first place we have respiratory alkalosis, right? pH was
Yes.
7.46 and carbon dioxide was 19. So it is
Mm-hmm.
respiratory alkalosis.
Mm-hmm.
We have metabolic acidosis because bicarbonate is decreased more than normal compensation. Okay,
Mm-hmm.
if it is decreased, so it is acidosis,
Mm-hmm.
right?
Yes.
And all these concepts are working in the opposite way. Okay,
Mm-hmm.
like if carbonate is high in metabolic alkalosis, we will accept only change of 4 in carbon dioxide. Okay, it will be normal.
Mm-hmm.
If it is not like this, it will be mixed type. Okay, so most of the time you will not see such difference, and you will understand it from the stem. If you have in a stem mixed type, then you have to check it. Okay, if you don't have mixed type in your stem, just straight go through the one primary. Okay, got it?
Yeah,
Yes.
got it.
If you have mixed type of options in your question, in your options, right, then you have to check it whether it's normal compensatory or not. If you don't have both, like metabolic acidosis and metabolic alkalosis, you don't have to look for the whole formulas. Okay, just go for primary problem. Okay,
Mm-hmm.
our time is up and we have only done 8 MCQs. Yeah.
Which of the following changes have most likely occurred in this patient since the onset of her hospitalization? 50-year-old woman come to the emergency due to cramping mid-abdominal pain. Image show a small bowel obstruction. Vital laboratory studies include CBC and comprehensive metabolic panel are within the normal limits. The patient is admitted to the hospital for non-surgical management. Oral intake is withheld and promote bowel rest. An isotonic saline infusion is administered for hydration. She has no vomiting and diarrhea, and after 2 days, the abdominal pain improves. Total administration of sodium chloride infusion was approximately 6 liters. Which of the following changes most likely occurred in the patient since the onset of her hospitalization?
So what do you think? What is the problem here?
So, the infusion of the normal saline, like
So it's
Yeah.
normal saline overload.
yeah.
Yeah.
Mm-hmm.
So they are infusing 6 liters of normal
Six
saline.
liters, yeah.
Now, be very attentive, okay? This is easy concept, but you
Mm-hmm.
have to be attentive, okay? What we have discussed previously, that normal saline is isotonic to plasma, right? Be with me, guys. Yes or no?
Yes, sir.
Yes.
Yes.
Yeah.
Yes, sir.
So
Yes.
this isotonic is means that water will not go in or out. Okay, I am explaining this because some students confused it with the composition. Okay, now what is the composition of normal saline? It is 154 sodium. You guys can look for the units, and but I am explaining the concept, and 154 chloride. Okay, this is the composition of normal
Normal
saline,
saline. Mm.
and they are isotonic to plasma, but what do we have here? Sodium is 140, right?
Mm-hmm.
and chloride is 100. So the composition, the point I am making is the composition is not same. Okay, the solute composition is not same, although it's isotonic. Okay, getting this
Yeah.
or not? Yeah. So what happened over here is in our question, what is happening here is we are infusing normal saline. Okay, so if we infuse that high normal saline, so what will happen to the plasma levels of sodium and chloride? Sodium is 142,
Mhm.
nu is 154. This is for sodium. And chloride is from 100 to 154. So which one is more affecting? Which change is
Increasing
more?
fluoride. Increasing
Chloride.
fluoride.
Chloride.
Yeah, so
Chloride.
you have almost got the complete question by getting this concept. Okay. So what will chloride do if we have increased chloride? So we got to the point that normal saline causing abrupt increase in chloride. Okay,
Mhm.
we got there, right?
Yes.
What is the, it is important in the anion gap. Okay, we are going there. Okay,
Mhm.
what is happening now is in no in plasma the cations are balanced by anions. Okay, got this? So
Yes.
whenever we have increase in chloride, we will have decrease in
Bicarb.
bicarbonate. Okay,
Mhm.
so what it will cause?
Acidosis, metabolic acidosis.
Acidosis. Got this? Which
Yes.
type?
Yes.
Metabolic. Everyone got this?
Yes.
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 Okay, so you are almost done with the question. Now tell me what will happen to the pH?
pH will be decreased.
Okay.
Decreased.
Sodium bicarb is,
Decreased.
we have excluded this. Okay. Serum chloride is
Increased.
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 hyperchloremic state. Okay. So we have got our question. Okay.
Mhm.
What about sodium? We have putting more sodium.
Increased.
We are putting more sodium in normal saline. So kidney is trying to remove extra
Sodium.
sodium, right? So you got your answer. Was it easy or not?
It was good. Easy.
Yes, it was easy from the way you connected it from normal saline.
Yeah. So anyone can repeat this? What is happening?
So
Normal
as
cell, normal
fused
saline do what?
normal
Causes
hyperchloremia,
isotonic plasma.
Yeah,
chlorine.
hyperchloremia. You know this?
Mm.
Why hyperchloremia and not hyper sodium? We can say hyponatremia. Why not? Because the difference was affecting more the chloride. Okay.
Yeah.
Mhm.
Yeah, you got this right. And this hyperchloremia is balanced by
Decreased
losing
by right.
losing bicarb,
Decreased
which
by
is metabolic acidosis. Acidosis
acidosis.
tells us low pH. Okay.
Mm.
And the rest we
Mm.
have seen. Okay.
So I guess
Yes.
over effect when bicarb gets less and chloride gets more.
Sorry.
This is some effect, right? When bicarb is decreased and chloride is increased.
Yeah, because I have told you that cations are balanced by, and now I am going after this very important concept you will understand. Cations is balanced by anions, okay? What are the
Okay.
important cations or plasma? Sodium,
Sodium,
potassium,
Sodium, potassium,
calcium, etc. Okay.
calcium, hmm
And what are
magnesium,
the anions?
Like
Chloride, bicarb,
bicarb,
bicarb.
and most important are acids. This is very important, okay?
Okay.
I will discuss this now, okay?
Okay, sir.
So you got your answer. My pen is not working. I don't know what is wrong. Yeah. So now I am going to explain a very important concept. I think today, like today is not we are doing MCQ, we are doing acid-based concepts, right?
Yes, sir. Yes.
Yes, and it's helping us.
It's helping. Yeah.
Yeah. So
Mm.
I'm happy if it's helping. So we were discussing that we have sodium, potassium, calcium in cations, okay?
Mm.
Yes.
And this is balanced by anions, which are chloride, right?
Yeah.
Tell me.
Chloride,
I'm waiting for you there so
bicarbonate,
that I could understand
bicarbonate.
that
chloride,
you are getting my
bicarbonate,
point.
and
chlorine,
hydrogen,
And
bicarbonate, and
and
acids.
I
acids,
and
okay?
acid. Yeah.
Now we have increased chloride, right?
Yes,
And
Yeah.
bicarb was decreased. We got metabolic acidosis, okay?
acidosis. Mm.
What if we increase acids?
We'll
What will
have
happen? What will happen? We
uh,
will have decreased
uh,
bicarbonate, okay?
decrease by
And we will have metabolic acidosis,
Alkaline.
right?
Um,
mm,
Getting this? If
Yeah.
we are increasing acids, we are getting acidosis, okay?
mm, mm,
Why? Because
so
the anions are balancing each other, so the bicarb is doing the work by
decreased.
decreasing,
Mm,
okay?
mm.
Now, tell me what is DKA? Diabetic
diabetic ketoacidosis.
ketoacidosis. We
Acidosis.
are we are having increase in ketones, okay? And
Mm-hmm.
it is
Mm,
in anion and acid, okay?
Mm.
mm,
Why it is causing acidosis? Because we are adding acids.
Reduction of
We are
carbon.
adding acids. Bicarb is decreasing, okay?
mm.
Got
Okay.
this?
Yeah.
Similar
Yes.
concept is for other acids, okay?
Mm,
So whenever you come to the questions and you see decay or other conditions I am going to explain now, you will have this basic concept, okay?
mm,
Now tell me, we are talking about anion gap, right? For some
mm.
time we have talked about anion gap sodium minus chloride plus bicarb,
Lost
okay?
by cows. Mm,
So in blood we have this and this also, and also we have acids, right? Other acids, okay? This one.
Yeah.
So whenever we have chloride effect, or sorry, we can I can make it simple. Whenever we have loss of bicarb, we call it normal anion gap acidosis, okay? Normal is 10 to 14. Okay, Getting this?
Yes.
But important concept over here is if we have increased acids, okay, we will call it elevated
Yeah.
anion gap. Some of you will be confused that you have told us that when acids increase, bicarb decrease, right? But you are now dividing it into two. Let me explain. If the problem is only in loss of bicarb, if the problem is bicarb itself, okay?
Okay.
If the problem is bicarbonate itself, it will be normal anion gap. Acidosis, okay? For
Mm-hmm.
example, if we have diarrhea, we are losing bicarbonate, okay?
Okay.
Mm-hmm.
We don't have any increase in acids in the body. We are losing bicarb, okay?
Mm-hmm.
Okay.
So the root cause of the problem is bicarbonate itself,
Mm-hmm.
okay?
Okay.
Mm-hmm.
Example is diarrhea, okay? Other
Okay.
example, renal tubular acidosis. What happens in renal tubular acidosis, we will discuss in types of RTA in pathology, but the net effect is we are losing bicarb from kidney. Okay, so again, the main problem is what? In bicarbonate itself. Okay,
Mm-hmm.
we are losing bicarbonate. Okay, we are not putting acid to our body. Okay, we are
Mm-hmm.
losing bicarbonate due to some problem in kidney. Okay, so first
Mm-hmm.
was diarrhea, now kidney. And the last thing is these three are the high yield, important high yield causes of normal anion gap metabolic acidosis, which is excessive saline, yeah, saline infusion. Okay,
Mm-hmm.
got this? So, if the problem is in bicarbonate itself, it will be normally 9 gap. Okay. The examples
Mm-hmm.
are diarrhea and RTA. Okay. And and if we have increased chlorine. Now tell me
Mm-hmm.
anyone, when will it be normal in 9 gap acidosis?
When there
First.
is only
So
loss
there's
of bicarb.
diarrhea, RTA, or excessive sodium
No. Tell
infusion.
me the concept.
When
If
there's only
first,
bi it decreases.
yeah, if the problem is bicarbonate loss
Mm-hmm.
itself, the problem is bicarbonate itself. Okay.
Mm-hmm.
Okay.
And the second is if we have infused chloride, like in norma saline. So now is a high yield concept. You know the concept. Now you have to remember diarrhea,
Mm-hmm.
RTA, and saline infusion
Excessive.
causes normal anion gap metabolic
Yeah.
acidosis. So
Okay.
now, if you come with any question and they have told you that we have infused a large amount of normal saline, you will straight go to normal anion gap metabolic acidosis. Okay, you know the concept,
Yeah.
right?
Yes. Mm-hmm.
So it will save your time. Okay, but
Mm-hmm.
if we have poured or we have increased acid like in DKA, diabetic ketoacidosis, right?
Mm-hmm. Mm-hmm.
If in STEM we have diabetic ketoacidosis,
Mm-hmm.
High
give me a
anion gap. High
give me
anion gap metabolic
okay,
acids.
okay. Give me examples so that I should know that you guys are understanding it. First exam, example is DK, right? We are putting
Mm-hmm.
ketones, okay?
Yeah.
Ketones.
What can be the other cause?
Carbon
So
monoxide poisoning.
I am making it easy for you. What happens in renal failure? We have toxins accumulation, right, in our body.
Yeah.
Mm-hmm.
Yeah, so we call it uremia.
Oh,
So if we
Mm-hmm.
have in our
uremia.
stem like CKD, or they have given you increased CRET,
Creatinine.
BUN, right? So all
Okay.
Mm-hmm.
this means that we have increased
Renal failure.
toxins, okay? We
Okay.
have increased acids,
Mm-hmm.
and we have elevated A9 gap metabolic acidosis,
Mm-hmm.
right? Got this or
Yes.
not?
Yes. Anytime acids are increased, it's like metabolic
Yeah.
acidosis.
So you guys have to memorize, because you know the concept, right? You have
Mm-hmm.
to have the memory of DKA, renal failure, and alcohol. Alcohol
Okay.
toxicity will cause elevated anion gap metabolic acidosis. Okay, what can be
Mm-hmm.
other problems?
Acidosis.
Alcohol like methanol, and some cases of poisoning like we come along is ethylene glycol. We call it antifreeze or something like that, right?
Yeah.
Yes, yes,
So they are same.
antifreeze.
Freeze alcohol.
The last one is, sorry, not the last. Yeah, similar lactic acid, right? Lactic
Yeah.
acidosis.
Mm-hmm.
Okay,
Okay.
Mm-hmm.
and last will be
Salicylic poisoning.
salicylic acid, aspirin poisoning. Okay,
Poisoning.
so I
Mm-hmm.
think you have got the concept of acid base, right?
Very good.
Mm-hmm. Yeah,
Thank you.
I love the way
Thank you
you
so much.
explained it.
Yeah, you make it
Thank
very
you.
clear. Thanks a lot.
Mm. Simplified manner.
Yeah, okay. So what we are going to do now is on all the lecture, because of all the lecture today, what you guys will do? You guys will do some of your MCQs by yourself, right?
Mm-hmm.
Yeah, right
Mm.
or not?
Yes,
Okay.
yes, yes,
Oh.
we will. We will. If we
Okay.
have
Oh my
any
God.
difficulty,
Hi,
we'll bring it to you.
Thank you,
Dr.
thank you,
Hashim.
Dad.
Dr. Hashim,
Yeah.
can
Thank you.
you, did you able to record? Did you able to record?
Yes, it's being
Yes, it's
recorded. I'm
recorded.
saying.
Oh, okay.
So when
Because
is it? When is the recorded section be released? When
Sorry?
will it be released? When will the recorded session be released today?
Sorry?
When will it be released? The recorded section.
Yeah, so
That's
I will put it in an hour, okay? Because we have
okay.
the problem we have is we are having continuous classes. Like before this class we have the marathon class, and after this class we have a micro class. So all the recordings at the same time are going on, and the next classes is coming. So that's why the recordings got late, okay? So don't worry.
Okay. Okay, got
So
that. Thank you.
I'm going to do
Can
one
we
or
get
two.
can we get the question in the group, because yesterday even there was like
Yeah,
two three
so
question remaining, we didn't get those
the
one even.
sorry, doc, what's your name?
My
Yeah,
name is
yeah,
Marwa.
please.
Marwa.
Yeah. Okay, Dr. Marwa, I think if you don't mind, you are asking about continuously asking about the questions, right?
Actually,
Yeah,
yesterday the
if you don't
suggestion.
mind. Yeah, so what I would favor you, that I would do something for you in our question bank subscription, okay? I think
Yeah,
you're very worried,
I
okay?
no, there's no problem. I have my own subscription. I'm not worried actually about that.
Yeah.
Yesterday it was discussed that either we have
Yeah,
to,
yeah, yeah,
because
yeah.
the
I'm
question
sorry. Yeah,
IDs is
Yeah.
making a problem.
yeah,
So
yeah.
although I have my own
So,
subscription with
so
me, but I
yeah.
couldn't correlate the question number with those
Yeah.
because the
Okay.
number is different here with
Yeah.
those.
Yeah,
So this
so
is the
I
actual
got,
problem.
yeah, I got your concern because most of the students were telling us that they have their subscription and the question IDs are not matching, right?
Same.
Yesterday we have
Yeah.
talked about this,
Yes,
right?
sir, that is true.
So,
Yeah, because
yeah, so what we
it's a
gonna do
uworld
is,
transcription,
yeah, so what we
subscription, and
gonna
this
do
one.
is, what we're gonna do is that I was sharing the previous three questions that I have left for the homework that I am going to send it. But then I thought that it would be causing like some problem for us that to share each and every MCQ. So I would suggest what will be more important and more helpful for you guys that we have done with Palmo, right? You know this, right? We have done with Palmo, and I think we should have left 10 or 15 questions or 20 questions for you as a homework, right? So if you guys want to cover the questions that are left, you guys should be doing the previous module. So what it will help that you will be going the U world the second time, okay? And it is very very much important and very much helpful if you go through the U world again, okay? So for me I will share the screenshots. I will do whatever ask me, but I would suggest that important for you guys that you guys also do the questions along with us, okay?
So the thing which is making me confused actually, like you ask, I'm
Yeah.
asking about the question is this, like if I already got the subscription, I'm doing that one. So it make me on the track that how much I covered and what's my percentage, what are the weakness. If I gonna jump from one viewer subscription to another one and then start
Yeah,
from the
yeah,
very
yeah.
beginning, it make me
That's
confused and the
very,
thing
yeah,
will go haphazard for me. It's not the
yeah, it's
problem
a
that
very very
I can get the
relevant, yeah.
AC subscription, but it's making me confused, like
Yeah,
on two
it's very
subscriptions. So this is
relevant.
the actual.
Yeah, you are
So this is the
saying very
problem for
accurate
me.
thing. We do not recommend to make your score haphazard, but I am suggesting that if you want to cover the question that are left, like we are almost done with the physiology, right? So we have done in physiology like 30 or 32 questions yesterday and today, okay? So the total questions in the physiology section in your U world also will be 40 to 45, right? We have almost 13 remaining, okay? So we are done with the 30 questions and 13 are remaining. So if you want to do the questions, you can do it that way that you can go through your own question bank and you will see these questions in your own question bank. Or I can, what I can do for you is I am suggesting that way and I will do send the screenshots, okay?
Okay, thank you very much, sir.
Okay, sir.
Thank you.
So, should we end the class or we should do an MCQ? Yeah, this one is very interesting and easy one, so I am going to do it, okay?
Okay, sir.
Sorry, Doctor, I have a question. I just joined you guys newly. This should be my second day. I wanted to find out how many classes do we have in a day? Like
Uh,
after your own section, are we going to have another class?
so if you want to join the other program, yeah, you can
Mhm.
have. But yes, currently in our program, we have this class only, and some of in week or 2 weeks we will be adding a class or two of the micro section. Okay, so your bacterias of the same system will be covered. Okay.
Okay. Okay.
Yeah. So this question is asking that the majority of the total amount of water filtered by individual glomeruli is absorbed in which of the following portion of the nephron. So they are asking about total amount of water is reabsorbing from which portion. Okay. So a 54-year-old traveling, what is this saying? Traveling in the remote region of South Asia became lost After several days, he arrives at a village. However, he has gone 24 hours without food and water. So, overall stem they are saying is, what do we have?
Dehydration,
Dehydration.
What it leads to?
increased urine osmolarity, and
Increased in
Increase
osmolarity of
ADH
urine.
secretion will increase.
So,
Increase
I think,
ADH.
guys, we have yesterday discussed the osmolarity questions, right?
yes.
And
Yes.
in our coming questions, we have three similar more questions, and it is very easy. Okay.
Okay.
Yeah, I am going to explain. I think I will do one of them, and you will do the remaining. Okay. So, what do you think? How the water reabsorbed is
It's
from
in
which portion?
collecting duct, the medullary.
Collecting.
collecting duct.
Anyone else?
Last part,
Loop of Henley.
last part DCT as
So
well.
we have collecting duct.
Proximal
We have
tubule.
It
loop of
could be loop
Henle,
of Henle also.
and
Proximal tubule.
so one of our doctors is saying proximal convoluted tubule, and actually she is right.
Yeah, 60% of water and
Yeah,
sodium
great.
is the PCT.
So
Yeah.
the concept over here, I thought I told you that it's a interesting question because the concept over here is the 65% is reabsorbed in proximal convoluted tubule,
Osmolarity.
and the ADH is managing only
Collecting ducts.
25%.
25.
Okay, this
Mhm.
25% is doing what? Either concentrated urine or dilute urine. Okay,
Dilution, yeah. Mhm.
so most of it is reabsorbed in PCT,
PCT,
proximal,
PCT.
and ADH is managing 25% in collecting ducts.
Mhm.
Hmm.
So be careful in doing MCQs like that.
Sir, can you tell something about loop of Henley? What's going on over there?
Yeah, I think, yeah, 65. I think it's like the 65% in PCT, okay,
PCT, yeah.
15% in loop of Henle,
Mm-hmm.
I think 10% in distal, 5 to 10% in distal convoluted tubule,
Mm-hmm.
okay. So how much it becomes? 80, 90. So 10% is in cortical, in collecting tubules, okay. It is in normal conditions, okay.
Okay.
But when we have ADH, it can do the reabsorption up to 25%, okay.
Mm-hmm.
Can't go more than PCT.
Okay.
Okay. And
Got this?
the ADH usually come from the collecting duct, while the
Yeah, it
65
is
come
affecting
from.
on collecting duct, okay.
Okay.
Collection duct, yeah. Mm-hmm.
So I think you got this concept right.
Mm-hmm.
Yes.
So I'm going to do here is, I think it's,
But one more, that the loop of Henley is reabsorbing water without salt, yeah? We have to mention as well. Loop of Henley. Just
yeah, yeah,
water
yeah, yeah,
without salt.
well,
Uh-huh. Yeah.
yeah, the descending loop of Henle is only permeable to water, while the ascending is only permeable to salts. You're right, okay? Right?
Can you repeat this concept, please?
Sorry, it's not about this question. It's previous, okay? So what she was saying that if this is the proximal convoluted tubule, this is the loop of Henle, okay? This is the distal, and this is the collecting ducts, okay? So she was saying which part is water permeable and which is not. Okay, so this part, descending loop of Henle, is permeable to water only. Okay,
Mhm.
Okay.
And this part, ascending lip, is only permeable to solutes, or we can say salts, okay?
Okay.
And till here, okay? So this part is affected by hormones like ADH, aldosterone. Forget about it. But one concept is this and other is this, okay? And what about the last part? What about this collecting duct? This is relative permeable, okay? What does it means? Anyone? Relative permeable to water. It means if we
Depends on
have
the ADH.
ADH, we will have increased permeability. If we don't have ADH, we will have decreased permeability. This is permeable to water, not solutes. This is permeable to salts, not water.
Not water.
Or this. So I think we should start our another program that we should be studying the topics and questions both, right?
Exactly.
Yes. Yes, you're right.
Yeah. Okay.
Yes.
So let me give you this question. Anyone, please? Yeah, be
Which of
quick,
the
guys.
following areas
Which of the following areas of the nephron is normally impermeable to water regardless of serum vasopressin levels? So here we have a 34-year-old woman who
Yeah.
comes to
So
the physician.
let me interrupt. Sorry,
Okay. Okay.
but
B.
the STEM is not that much important. You guys can
Okay.
look into it after. But what are they asking? Which of the
B.
following nephron is impermeable to water?
Mm-hmm.
Now told me.
D.
Is A impermeable?
No.
Is
No.
B
No.
No.
Yes.
No.
No.
is
No.
It's D.
permeable? It is
Is the
This
D?
permeable
is
to
Is
B.
the
water.
B
D?
is permeable to water.
Yeah.
Is this the
Yeah,
D
so we
part?
have
The
we
D.
have yeah, we have discussed it, right?
Yes. Is D impermeable to water?
Let's check let's check that we are right or wrong, okay? Yeah, you're right.
Yes. Yeah, because you told us.
Yeah, one other question I have seen of the same concept. Maybe it was like this. Let's look into this. Maybe it is. Anyone please read this out?
Which of the following nephron segment respond to vasopressin by increasing absorption of a specific solute that is important for generating a high medullary concentration gradient?
Yeah. Is it completed?
No, I feel like we do not. Okay.
Yeah.
A 34-year-old missionary in southern Asia is traveling to a remote village and becomes stranded when his bus breaks down. He has no access to water for 36 hours, during which his urine osmolarity reached 1,100. Urine concentration depends primarily on the serum level of vasopressin, which is regulated by the neurohypophysis in response to plasma osmolarity and blood volume. Which of the following nephron segment respond to vasopressin by increasing absorption of a specific solute that is important for generating a high medullary concentration gradient?
Yeah. So what is vasopressin?
ADH.
Where
ADH.
does ADH act?
Collecting
Medullary.
duct.
Yeah,
Medullary.
medullary.
Collecting
Medullary
duct.
part, collecting
Collecting
duct.
duct.
Yeah,
CD.
medullary.
CD. Collecting duct.
Yeah. And
Medullary
we
part.
have collecting duct and collecting duct here.
Mm-hmm.
So
Mm-hmm.
medullary segment or cortical, which one?
C, C, C.
Medullary segment.
Medullary.
Medullary.
Because we
Yes.
have hyper What?
Yeah, hyperosmolarity.
Hyperosmolarity
Mm-hmm.
in here. So let
Mm-hmm.
me ask you another concept or question. Who is responsible for making the medulla hyperosmolar?
Urea.
Urea.
Yeah.
You're right,
Urea.
urea. And
Mhm.
okay.
You
And
mean
what are?
you mean asking about aquaporin?
No, I'm asking
Uh-huh.
about what are the ions that are responsible for
Ah,
and what are the mechanisms that are causing medullary hyperosmolarity? You have studied it. Anyone, please?
Water retention.
Counter current.
yeah, counter. Oh
Yeah,
my God.
you all
Yes,
know this.
counter.
Current multiplier.
Mm-hmm.
Mm,
Yes.
yeah,
Mm-hmm. Yes, yes, yes.
and other is urea recycling. We call it urea
Urea
cycle.
cycle. Как он
Okay.
сейчас?
Please, I don't get it. Can you come again? I didn't understand how
Okay.
you yeah.
Yeah, so we were saying
Mm-hmm.
who is responsible for making the medulla hyperosmolar. The
Mm-hmm.
osmolarity in medulla goes to 1200.
Mm-hmm.
So who is responsible? We have some of our students says urea, which is
Mm-hmm.
correct, and
Yeah.
sodium and chloride. Okay.
Yes. Counter
Mhm.
record exchanger. Yeah. Like
Yeah.
it
So we
yeah,
have
yeah, very important loop of Henley. Yeah.
yeah,
Mm-hmm.
yeah, you know that.
Mm-hmm.
So we have counter current mechanism and urea
Mm-hmm.
cycle. Okay.
Mm-hmm. Yes, yes.
Okay, thank you.
You're welcome.
So if anyone let me ask the team, I think we have another class, okay? If anyone wants to join,
Yes.
the class is all for the marathon group, but I think they are doing TB microbiology, okay?
Mm-hmm.
So the questions on TB they will be doing. So you have done with your Palmo, so I think you should take the class, okay?
Okay.
Okay.
Sir, Dr.
Thank
Dennis is
you.
gonna take skin classes as well.
Sorry?
Dr. Dennis is gonna take a skin class. Would he take or not after completing skeleton?
Yeah, so Doctor who? Doctor who?
Dr. Dennis.
No, I think before our class, we have marathon class of Dr. Samir, I think. So I will text you in our group, okay? I don't know who takes the class, okay? And after this one, we have micro class. Dr. Ali will be taking it, okay?
Okay.
Um, Doctor, please, I asked you before about joining the marathon
Yeah,
class, and
yeah,
you told me to contact the admin.
yeah,
How do I do that? Because I tried sending a message, but nobody
yeah.
responded.
Yeah, you are in which group? Sorry.
I mean, the group. I don't know which group I'm in.
You are in our ASU World discussion group, right?
I am in the discussion group and also in the batch 10
Yeah.
and
What you can do now is just mention Dr. Hashim, okay, in whichever group you are, okay, and I will text you, okay? I will text you back, okay?
all right. Thank you, doctor.
Yeah, I'm
What
waiting
about
for
the
your
system
text,
Baba?
okay?
I will
Sorry?
send text.
The system Baba, the August batch, yeah.
Yeah, for the August batch. Yes.
Yeah,
The
the
one
No, no,
which
no.
August,
will
For the
start
new
September
coming
4th.
batch, you
Yes,
said the
yeah,
August batch is finished. That I should join the new batch that is
September
starting
Baba.
now.
yeah, yeah, we will be starting a new batch in, I think, in a couple of days, okay?
Yes, that's what you said.
So, whenever group you are, just text or mention Dr. Hashim. I will respond. Okay.
Okay, Hashim.
And we
Okay.
will. Perfect. Thank you, guys.
Thank you.
I will appreciate your suggestions and feedback. Okay.
All right. Okay, doctor.
Thank you.
Thank,
Thank you so much.
thank you so much.
All right. Take care. Bye.
Bye bye.
Bye. So.
Hashim. How do I spell? Okay. Hashim.